have no relevant conflicts of interest. To begin with the end in mind, there have been two historical treatments for Lisfranc injuries. The first is a primary fusion, and the other is drilling holes through articular cartilage. As some background, the name Lisfranc comes from a French surgeon back in the 1800s who described an amputation through the tarsal-metatarsal joint from an injury on a horse. In 2022, the name really represents an injury to the arch of the foot. Really, this arch spans both the longitudinal and transversal arch and is important for gait. The importance lies in the relationship of the second metatarsal in this arch because it acts as the keystone, much like an architectural arch. The anatomic considerations here are the ligaments of this joint, particularly the dorsal, interosseous, and plantar ligaments between the first metatarsal, the second metatarsal / medial cuneiform. This injury is important because it's very non-homogeneous. You can see on the left, these are both Lisfranc injuries, but one is very different than the other. They can be both bony and ligamentous, and they can be missed in up to 20% of the time. We know that they're highly morbid. At best, these patients lose, on average, points on the AOFAS score, and we do know that anatomic reduction is necessary to really get a good outcome. There's historical treatment classification systems really dating back to the 1980s, incorporating some of the mid-tarsal involvement. But really, this doesn't really help us in treatment algorithms. Nunley proposed one in 2002, which really helps us with that, where essentially we fix displaced injuries. However, we've come to appreciate more this proximal variant, which is important to identify and be cognizant of, where this injury extends up that Lisfranc complex into the relationship between the middle and medial cuneiform. We want to be highly suspicious after a patient presents with a foot injury with swelling and ecchymosis in the arch as well as an inability to bear weight. We want to be very suspicious of these injuries. We get x-rays, try to get them to weight bear if possible, and if possible, consider a stress x-ray in the office. Oftentimes patients don't tolerate this. We're looking for this flex sign. This is one hallmark sign of the injury. And then we want to look for other things such as drifting of the metatarsal dorsally or incongruency of our angles and lines on the oblique view / the lateral side of the foot, particularly the third and fourth metatarsals in their relationship to the lateral cuneiform and the cuboid. Still then, sometimes patients aren't able to bear weight or tolerate any of these exam maneuvers, but we're very suspicious. In this case, we get a CT or MR. MR is helpful in demonstrating edema and fractures as well as ligament disruption. Ultimately, however, our diagnosis is going to guide our treatment, which is centered around obtaining and maintaining an anatomic reduction. This can be non-operatively in non-displaced injuries for 6 to 8 weeks non-weight bearing, or in displaced injuries in open reduction and internal fixation versus a primary fusion. Both of these are viable options, and I would argue that it's rare in orthopedics for a fusion to be treated as a primary treatment modality, particularly when there's no bony injury, which is the case sometimes. We're still talking about fusions. Maybe this is just because we don't understand what the best method is to fix these, because even despite our best efforts, up to 94% of patients develop post-traumatic arthritis with fixation. What's the best method? Well, I just really don't know. I've tried a bunch of different methods. My notion is that drilling holes through the articular cartilage seems like a bad idea, and so I think that's a place to start, because this is what we're left with if you are performing this historical fixation of the tarsal-metatarsal joint. So this is sort of our method today. These are some of our post-operative x-rays and a few different varieties of injury. And what is this based on? Well, this dorsal planing across the tarsal-metatarsal joints based on this cadaver study, which demonstrated there's no difference in ability to maintain reduction with loading with a dorsal plate versus a transarticular screw, and then this study as well. But this study did also demonstrate that there is some gapping plantarly with the dorsal plate after cyclic loading, which makes sense because that is the tension side of the construct. So we did a study in 2019 published in FAI where we looked very carefully at the articular surface. And so looking back at the medial cuneiform, you can see the cartilage is dorsal and proximal. Looking over towards the middle cuneiform, from the medial cuneiform, again, you notice that the cartilage of the second metatarsal and middle cuneiform is dorsal and proximal. What this does is it leaves us a screw path / trajectory that can be non-articular if you're careful about the way you place the screws. And so this is sort of our screw path and trajectory. How do we get these screws in the right spot? Well, we start with a 1-2 intermetatarsal space longitudinal incision. And the first structure that we're looking for, in addition to the dorsal mediocutaneous branch of the superficial perineal nerve, is we're looking for the musculotendinous junction of the EHB. Just deep to this, pretty reliably, as published by Loveday in 2013, lies the deep perineal artery and nerve. And then that allows us, once we've identified that, to create windows down on to the first and second tarsal metatarsal joints. Immediately, we want to look for the tib ant and its insertion on the medial cuneiform and first metatarsal. This is the screw that we're looking to place. How do we place that screw trajectory? Here's a coronal plane MRI. In the red there is our dorsal joint. So our screws, we want that to be plantar to this. It actually helps, I believe, to look at that dorsal lateral corner of the second metatarsal, demonstrated by that blue arrow on our dissection, and then we're going to aim our screw plantar and medial. And so this is how we do it practically. I use a K-wire and usually use a cannulated screw, 3, 5, or 4 millimeter positional screw, but not in lag technique, because you can see in that left image I'm holding the joint reduced with a clamp openly. I want to look at that joint, know that it's reduced before I place my screw. We subsequently followed up that study with a study after performing this level of fixation to prove to ourselves that these screws were non-articular, and we found that to be the case. So the downside of ORIF is the need for hardware removal at times. So lateral fixation, we tend to use K-wires, which we can remove, try to leave those in for 3 to 4 months. The medial fixation, we try not to take out for 4 months. And then plates, I would argue, if they're not symptomatic, even if they break and they're not bothering you, we don't take those out routinely. So fusion is still an option and should be a feather in your cap. And that's for these types of patients. So here's a 33-year-old with some subtle instability, 15 weeks out from a Lisfranc injury. The MRI demonstrates edema and evidence of disruption of the joint. So that's a good fusion candidate in my hands, just because 15 weeks out, it's going to be difficult to get any clinical benefit out of that. So what do we have evidence-wise to support fusion versus fixation? Well, there have been some randomized controlled trials, the summary of which is that the revision excluding hardware removal of ORIF versus fusion is equivalent. The patient outcomes tend to be equivalent. There are more hardware removals in the fixation group and less in the fusion group, but the reduction is the same. Taking one step down in the pyramid of levels of evidence to case series, there's been multiple case series of ORIF. In the AOFAS scores range from the 70s to the 90s. When you look at the case series of fusions, again, it's 70s to high 80s. So hardware removal is really the difference here. So now, should we take out the intra-articular screws? Well, remember, when you look at those randomized controlled trials that I just showed you, all of those studies use transarticular screws. So, I mean, maybe the rate of hardware removal is higher. We just don't have the evidence of non-articular ORIFs yet. There is a 23% incidence of deep perineal nerve injury after hardware removal, and I believe that's because that relationship between the nerve and the injury and the scar tissue from the primary fixation that gets scarred in, and so you're more likely to damage that nerve on the second time in. What's the correct answer? Well, the answer is we just don't know. I mean, you just can't treat these all the same. You do want to lay some crate because the outcome scores are poor no matter how you treat them. To some degree, they lose some function on average, and on average the outcome scores are lower than pre-injury. Fusions aren't without complications. I would point out that there is reported metatarsalgia and adjacent joint arthritis. But I think on average, if you wanted a one and done, fusion's the right answer because of that risk for hardware removal. And then in athletes, I tend to perform an ORIF more commonly.